Entwicklungsländer. In fast all diesen Ländern sind die Gesundheitssysteme schwach. Die Verfügbarkeit von notwendigen und sicheren Medikamenten, von qualifiziertem medizinischem Personal, von angemessener Pflege ist oft einfach nicht gewährleistet. Und wenn doch, stellt der Zugang der armen und besonders verletzlichen Personen eine besondere Herausforderung dar. Neben der medizinischen Versorgung sind aber auch Prävention, Aufklärung und Sensibilisierung sehr wichtig. Wie wichtig all diese Faktoren sind und wie verheerend eine schwache Gesundheitsversorgung sein kann, mussten die Welt, aber vor allem Liberia, Guinea, Sierra Leone, aufgrund der jüngsten Ebola-Epidemie schmerzlich erfahren. Die Epidemie konnte sich so rasch ausbreiten, weil wesentliche medizinische und präventive Maßnahmen geschwächt waren und die Epidemie führte zeitweise zum faktischen Kollabieren auch der Grundversorgung. Gesundheit ist ein prioritäres Thema der Schweiz in der internationalen Zusammenarbeit, im Agenda 2030 auch, weshalb eine gute Gesundheit trägt wesentlich zur Armutsreduktion bei. Indem wir uns für eine gute Gesundheitsversorgung der Bevölkerung einsetzen, dann schaffen wir die Voraussetzung dafür, dass die Menschen ihre Lebensgrundlage verbessern und so ihre Armut und Verletzlichkeit mindern können. Gute Gesundheit trägt folglich zu mehr sozialer Sicherheit, zu mehr Frieden, zu mehr wirtschaftlicher Stabilität bei. Einmal mehr diese Integration der verschiedenen Hauptthemen. Im Bereich der Gesundheit konnten in den letzten Jahren viele Fortschritte gemacht werden und die Schweiz trug hier maßgeblich dazu bei. So konnte die Zahl der AIDS-Todesfälle zwischen 2005 und 2013 um 35% gesenkt werden. Der Zugang zu Trinkwasser konnte vielerorts verbessert werden, auch dank dem Globalprogramm Wasser der DEZA. Das hat dazu beigetragen, die weltweite Kindersterblichkeit zwischen 1919 und 2013, also ungefähr in 23 Jahren, um die Hälfte zu senken. Und dank der Malaria-Bekämpfung konnten zwischen 2000 und 2012 weltweit 3,3 Millionen Menschenleben gerettet werden. Wieso engagiert sich unser Land, die Schweiz, akzentuiert im Gesundheitsbereich? Weil unser Land in diesem Bereich besonderen Stärken hat und also auch Verantwortungen. Erstens das internationale Genf. In Genf sind zahlreiche bedeutende Organisationen im Bereich globale Gesundheit angesiedelt. Die Weltgesundheitsorganisation, das Internationale Komitee von Roten Kreuz oder der Globale Fonds zur Bekämpfung von AIDS, Tuberkulose und Malaria. Genf ist die Welthauptstadt der Gesundheit. Zweitens das Know-how. Zu nennen sind hier zum einen die Unternehmen im Bereich Pharma, Chemie, Nahrungsmittel, die ihren Sitz hier in der Schweiz, einige hier in Basel, haben. Zum anderen gibt es zahlreiche führende akademische Institutionen im Gesundheitsbereich, wie das Tropen- und Public Health Institute, die technischen Hochschulen in Zürich und Lausanne und die verschiedenen Universitätsspitäler. Und drittens das unerlässliche Engagement der Zivilgesellschaft. Zahlreiche Nichtregierungsorganisationen wie das Schweizerische Rote Kreuz, Solidarmed oder Médecins Sans Frontières spielen eine wichtige Rolle bei der Entwicklung des Gesundheitswesens in Ländern mit geringem Einkommen und auch bei der Aufklärung der Schweizer Öffentlichkeit über Themen der globalen Sicherheit. Die DEZA arbeitet mit all diesen Akteuren zusammen. Dies erhöht die Wirksamkeit der Aktionen. Gemeinsam erreichen wir da auch mehr als alleine und dies rettet letztlich Menschenleben. Welches sind unsere künftigen Schwerpunkte im Bereich der Gesundheit und bei der Reduktion von Armut und globalen Risiken bei dieser Reduktion von Armut und globalen Risiken eine nachhaltige Entwicklung zu bewirken, konzentrieren wir uns auf 3 Schwerpunkte. Erstens die Förderung der flächendeckenden Gesundheitsversorgung durch eine wirksame Gesundheitsfinanzierung und die Stärkung der Gesundheitssysteme, also eine Basisgesundheit für alle. Zweitens, die Bekämpfung von Krankheiten, welche die ärmsten Bevölkerungsschichten betreffen, die vernachlässigte Tropenkrankheiten wie die Schlafkrankheit und Malaria durch Erforschung, durch Entwicklung neuer, effizienter Präventionsmethoden, Diagnoseinstrumente, Behandlungsformen und deren Bereitstellung für die Benachteiligten. Drittens, die Verbesserung der Gesundheit von Müttern, von Neugeborenen, von Kindern und die Verbesserung der sexuellen und reproduktiven Gesundheit und Rechte. Zur Veranschaulichung des Schweizer Engagements im Gesundheitsbereich möchte ich hier zwei Projekte der DEZA erwähnen. Die Schweiz spielte im Verlauf der letzten Jahrzehnte eine wichtige Rolle bei der Erforschung und Entwicklung neuer Behandlungsmethoden gegen vernachlässigte Tropenkrankheiten. Die DEZA nutzte die Fachkompetenz der pharmazeutischen Forschung und der akademischen Einrichtungen der Schweiz für öffentlich-private Partnerschaften, um Zugang zu Wissen, zu Know-how, zu Ressourcen zu bekommen und so Innovationen zu fördern. Ein hervorragendes Beispiel dafür ist das Projekt Medicines for Malaria Venture in Partnerschaft mit Novartis, das Ihnen später im Rahmen eines Panels vorgestellt wird. Dank diesem Projekt konnten unter anderem in 50 Ländern 250 Millionen speziell für Kinder geeignete Malaria-Behandlungen durchgeführt werden. Zweites Beispiel, die Ebola-Krise in Westafrika. Die Schweiz unterstützte die internationalen Anstrengungen, um eine globale Ausbreitung der Epidemie zu verhindern, mit einem Beitrag von mehr als 32 Millionen Franken. Damit wurden unter anderem Aktionen von Médecins Sans Frontières unterstützt. Über 2300 Menschen konnten dank diesem Engagement erfolgreich behandelt werden. Zudem wurden über 30 Tonnen Hilfsgüter verteilt sowie Präventionsmaßnahmen finanziert. Des Weiteren unterstützte die DEZA auch eine von der WHO koordinierte Koalition verschiedener Partner zur raschen Entwicklung eines Ebola-Schnelltests. Die Epidemie konnte weitgehend unter Kontrolle gebracht werden, dennoch bleiben sofortige Maßnahmen bei Krankheitsfällen, präventive Maßnahmen und generell die Stärkung der Grundversorgung wesentliche Herausforderungen. Kürzlich konnte im Kampf gegen Ebola ein wichtiger Erfolg erzielt werden. Unter maßgeblicher Mitwirkung von Schweizer Forschern wurde ein Impfstoff getestet, der einen Wendepunkt im Kampf gegen Ebola darstellen könnte. Dieses Beispiel macht Mut und zeigt, was durch gemeinsame Verantwortung und Zusammenarbeit erreicht werden kann. Mesdames et Messieurs, chers amis, depuis le début de ce siècle, l'engagement croissant de la communauté mondiale, en particulier aussi de notre pays, dans le domaine de la santé, a été fort et remarquable. Cet engagement doit être poursuivi et il doit même être intensifié. En collaboration avec des partenaires et avec les organisations internationales, la DDC a déjà atteint plusieurs objectifs pour améliorer l'accès aux services de santé, pour garantir le droit à la santé, mais il faut là aussi poursuivre et développer les efforts. Il reste beaucoup à faire pour réaliser un jour cette vision d'un monde sans pauvreté et en paix pour un développement durable, pour réaliser un jour notre vision commune. Vous qui êtes collaboratrices et collaborateurs de la DDC, vous qui vous engagez sous différentes formes pour l'aide au développement de la Suisse, vous jouez toutes et tous un rôle primordial. Vous jouez au fond un beau rôle. Vous jouez un rôle très important pour précisément aussi réaliser cette vision commune. Alors j'aimerais vous remercier au nom du Conseil fédéral et aussi en mon nom propre du fond du cœur, parce que vous êtes au cœur de l'action. Et j'aimerais vous remercier de consacrer vos forces pour celles et ceux qui ont le plus besoin d'aide, pour les plus pauvres, pour celles et ceux qui souffrent, pour faire briller ainsi les plus belles valeurs et les plus belles couleurs de notre pays. Merci beaucoup de votre attention et une très belle journée.
very few, almost 60% of the people earn less than $1 a day. Now, if they have malaria, if you count the loss of business, because most of these are subsistence farmers or they're doing some small-scale business, if they have, their families have frequent malaria attacks, it means that they are foregoing important work to keep.
Vì cho tu cũng có đón không à, khi bạn muốn lấy tâm hay bay đón cái đón hay chùa chiêm trong cõi tiếng nó ô cái nào bạn thấy ngay ông phải nhẹ tiến tới chúa cuốn tranh là đọc về ngay có chúa tiết cuốn tranh là ta vi vác hay đừng mình vi vác mình đâu mình bảo quá có bố sai cuốn tranh được nên bốn có cuốn tranh cuốn nhung bảo ai nhung cuốn tranh cuốn nhung nó được mơ nơi của bà mơ thì làm tắc làm ấy
que está así con malaria. Se repite, si se sana, así está el tratamiento. Ahorita está en tratamiento. Le da la fiebre, tenía frío, dice. Y así estaba. Yo pensaba que era fiebre simple, no estaba la malaria. Me siento triste. Me lleva al centro de salud. Ahí le sacan sangre y me dicen que está con malaria.
Foundation. Anna holds a degree in medicine and a master's degree in public health, as well as a degree in tropical medicine from the Institute of Tropical Medicine in Antwerp. Ms. Oates began her professional career in 1991 as a district health officer in Angola. She also worked as an emergency physician in Africa. We'll come to that later. And Ms. Oates is now, as I said, her head of the Novartis Foundation, an organization whose objective is to improve access to healthcare for people around the world and eliminate diseases such as malaria and leprosy. And then David Reddy. He is CEO of Medicine for Malaria Venture. Before becoming CEO of MMV in January 2011, David Reddy was a vice president at Basel-based pharmaceutical company Roche here in Basel. Mr. Reddy, who holds a PhD in cellular and molecular biology, completed a postdoctoral fellowship in molecular neurobiology at the Friedrich Miescher Institute here in Basel. Medicines for Malaria Venture was established as a non-profit organization. We'll go into the depth of that in 1999 with the objective of discovering, developing and facilitating access to new anti-malarial drugs. And Alexander Schulze. He's advisor health systems strengthening and financing at the SDC. Alexander Schulze is a specialist advisor on global health at the Swiss Agency for Development and Cooperation. Prior to taking up this position, he worked at the Novartis Foundation. Mr. Schulze holds also a PhD, was born in Germany, where he studied development studies and social anthropology, before completing part of his academic training in Norway and then doing a postgraduate course on developing countries at the Swiss Federal Institute of Technology in Zurich. Prior to taking up his position at the SEC, he worked at the Novartis Foundation, so you two know each other, of course. Now, we've just seen the situation at the very heart of the problem. Children, farmers, families in absolute poverty who are struck with a fatal disease. It's clear that for these people, gaining access to medicines, gaining access to diagnostics even, and vaccines is influenced by many, many factors. Alexander Schulze, I'd like to start with you. can you name some of these concrete factors that favor medical access for patients?
Yeah, I probably want to turn it around, because I think the example we saw was very telling of what malaria can do to people and people affected by malaria. We probably saw more of the consequences really, and if I turn it around and say what are the obstacles, and we can probably take a concrete example of a child under 5 years of age, a group that is really at risk in terms of malaria. And the first obstacle can be information. We've heard of the Federal Councillor that access to information is key. So parents may not even know that a high fever or shivering of a child means that could be malaria. So the problem already starts there. And even if they know at some point and they want to bring the child to a clinic, they need of course cash. We are all aware of that problem, that you need to have some resources to be able to pay for a health service, especially in countries like Africa where you don't have health insurance. You can't just go and you're not covered. And at the end, if you even then reach that clinic, you need of course a quality diagnosis and you need appropriate treatment. And at the end, it can mean that your fever is not even malaria, but it is any other health condition. And if a physician doesn't know or is too much concentrated on malaria, it can be another obstacle to appropriate treatment. So probably I stop here just to give a few of these obstacles.
So maybe that gives us a chance to go to David Reddy and Arts. You've both been in the field, of course. Can you tell us one particular story, perhaps, that would illustrate these consequences when you can't get access, or when you get access and then you have a better way of dealing with these problems?
Thank you. Maybe just two examples. I think one of the first is that the patients with severe malaria, often when you first see them, they're in a coma. And so they're brought into the hospital or the healthcare setting if one exists in a state of coma. We've recently introduced with our partners an injectable drug now that prolongs life or reduces death by around 35% versus the older drugs. And I think one of the most telling examples was one of our team coming in and actually seeing one of these people in a coma, and they were administered this drug, and the next day they were awake, they were able to eat, they were able to take normal medication. Just one other example that I experienced personally, which perhaps is a deviation but taught me a real lesson, was in my first month in my new role at MMV. I went into the field, and I was out in the field in Ethiopia, and I saw a young girl who was probably around 4 years of age, who had been brought in with malaria. And she'd been treated and she was recovering, but what I really noticed was that at the same time she had severe malnourishment. And a baby in a bed beside her had no parents because they'd both died of AIDS and had been adopted by a family, and herself was probably HIV infected. And it just made me realize that it's not just about malaria, it's about overlapping issues, which is why the multi-pronged approach that Swiss Development Corporation is taking is so important.
So overlapping issues, the interconnectivity of all. Have you experienced something like that, similar to that, Ms. Arts?
Absolutely, and I think it is definitely not limited to malaria, but if people cannot reach health services in time, or reach health services where there may not even be enough human resources available to take care of everybody who presents, even if the drugs would be available, it would not be enough if there's not a good health service available. What Alex said, I really experienced that in several occasions, and people arriving too late in the health services is the worst, because then you have severe malaria, children coming in coma, and I have been faced with that situation several times where you cannot save the child anymore, and there's nothing worse than that. But even if I would think about a more recent example in my fieldwork, in another neglected disease is leprosy, where I met in India a young boy who was 10 years old, more or less, and he already had neurological damage because of the leprosy disease. He couldn't close his eyes anymore, so had to wear sunglasses, was crying all the time, couldn't use his hands anymore, had a claw hand. And I have a daughter of 10 years old, and I know the only thing they want to do is have fun. This boy, he didn't even get a chance in life. If he would have diagnosed a little earlier, we would have avoided that he had these disabilities, because the treatment is efficient. You can avoid that people get disabled because of leprosy. So it happens all the time. The lack of access or the late access to healthcare is a serious problem. And specifically, I want to underline the work in complex emergencies, like in conflict areas. It's even worse, because there the access problem is not only for the patients, but also for the healthcare providers. When you live in an area where it's unstable or not secure, which I also did, I was working as an emergency physician in conflict areas, the main problem we had is that our staff, from the medical staff, was so scared to come to work in the morning, because they had to come from their villages to the city or the larger village where the hospital was, and they were running a lot of risks on that way home, back and forth. So it is very difficult to be a healthcare provider in those countries. I also wanted to stress that from that point of view.
Thank you. So we will focus on the access to medical products now in this panel. If we talk about research and development or innovation, what does Novartis Foundation do exactly?
Thank you. Where the company really focuses on access to medicines to bring the innovative therapies to the markets in everywhere where it's needed, Novartis Foundation works on access to healthcare. So we have a complementary role to the company in the sense that we are currently developing innovative models of health service delivery. We feel that the need for innovation in many of the low and middle income countries, specifically for infectious disease, but also for non-infectious disease like hypertension or diabetes, the need there is really innovative delivery of services, because there are not enough health services available. All the services are geared towards acute care, and there's no services available for chronic care, for example. So we develop and validate new models for healthcare delivery in these countries, and when they work, we scale them up with government or with other partners to make a real impact on the health of the poorest populations. And currently we focus specifically on urban poor populations for cardiovascular care, as that has become the disease of the poor nowadays in many of these countries.
That's a new development, yes.
So we talk about research and development of medicines. That's probably, you know, at the beginning of this chain, you need to have products to be able to treat people, for example. And that we really do at global level. You see, these are people who are organized at global level, because a lot of countries are concerned. So it's research and development, you would not organize country-specific or country-based. And then I think we will hear in the afternoon, we try, of course, through country-based work to address access obstacles that basically happen in the countries, like the healthcare services, the provider side, is the personnel qualified to health financing, because we believe that we need to basically empower the patients and the people that they can access, and affordability is important, they need to be able to pay. So building up insurance is one way, but also basically empowering patients and communities to know about the rights. I mean, what are the services you're supposed to get? How can you get better organized to claim these services? And I think Anne rightly said, I mean, a lot of providers are in a very difficult situation, so it's not about confronting necessarily the two sides, but see how they can work better together, better communication between provider and patient, sort of mutual understanding for each other's situation. These are all elements you can address on country-specific level. But certainly, like affordability, you know, insurances, other financing mechanisms that help people to access care and access to information is very important. Perhaps a last point, because we talk about health and SDC, and I think development work is more than that. What we need more is more this sort of cross-sectoral work. When you think of access, you know, one way is giving people insurance, but at the end of the day, they need purchasing power. So anything you can do in terms of income and employment will eventually somehow implicitly have impact on their health or food security. And I think that's what we try a lot at SDC with the global programs that are not just health, is food security, other issues water, and these things are all sort of interconnected if you want people to access care at the end, because they need other elements which are not specific to health.
It's a real issue of poverty in the end. Yeah.
Absolutely.
It's not a sprint, it's a marathon. So sustained commitment.
Thank you very much. Thank you very much, Anna Ertz. Thank you, Debbie Reddy and Alex Schulze. Thank you.
Formerly a British Somaliland protectorate. It lies between la côte française des Somalies, la République de Djibouti of today, and la Somalia Italiana. And I think I'll just point to it, if my thing works, la République de Djibouti, le Somaliland, and la Somalia Italiana that you all know. To the north we have the great ocean, 850 kilometers of sea, and to the south we have Ethiopia. So that puts my country in perspective. My country is one of the least developed countries in the world. It's known poverty, it has known war, it has known drought, and in fact this year we're facing another very bad drought because the rains have failed. And there's going to be poverty, of course, people are going to lose their animals, and there's going to be suffering. And many years of war between 1982 and 1991 have caused a lot of damage and destruction and death. And I'm sorry I have to show you this, but this is what war brings. People are killed, women, children, and I fail to understand what the military value is, what the heroism is of killing women and children. But that's the reality. And of course, when you have war, it destroys what you have. It destroys homes, hospitals, and any infrastructure that might be there. For the past 24 years, fortunately, my country has been peaceful. It has been stable, it has a government that is democratically elected, we have political parties, we have a constitution, we have our own currency, we have our own passport. So what is the problem? The problem is that women are still dying. Women are still dying of causes that no woman in this day and age should die of. They're dying of causes that you, the plural you, the world, elsewhere, has been able to protect women from dying. And you say, but preventing a woman from dying of eclampsia is such an easy thing. There is the good old sphygmomanometer. You can see her puffy face. You can see her ring that is too tight. You know that this woman has toxemia of pregnancy. Therefore, we can control What is causing this problem to this pregnancy before she loses the baby, before she loses her life? But then there are realities in this world. There are countries like mine where a woman will go through a pregnancy again, and another pregnancy, and another pregnancy, before she has ever been seen by a health professional. These are the women who die. My country, as beautiful as it is, we still lose. We have a maternal mortality of 1,400 per 100,000 black births. That's one of the highest in the world. We lose children. Our children die of causes that no child should die of. We lose 90 children out of every 1,000 children before the age of 5. We lose 42 children out of 1,000 during the first month of pregnancy. Why? Because there is nobody there to treat that newborn child, to help it. 100 trained doctors. Imagine, it's what dreams are made of. It's what my dream is made of, to have 1,000 midwives for my country one day.
Like to give you an update of the world. I'm obsessed by the world. And I'm going to do that by starting as a professor is allowed to do, by asking you questions, instead of you asking me. So I have 6 questions about the world.